vascular function. Okay, and again, I apologize about that screen. I'll keep playing with it. Okay, so just to kind of refresh you and remind you after our little break here that we had, that we left off last week sort of laying the groundwork for cardiovascular function. Promising today that we would spend more time sort of getting into the nuts and bolts of some of the major alterations of cardiovascular function that you'll be seeing in your clinical practice for the rest of your life and your career. Now, there's a lot of information in this chapter, chapter 23 in the text. I don't know if you've looked at it or not, but what we are going to really focus on here in class and for the purposes of our objectives and for the purposes of what you need to know for the exam is really three major things. One, coronary artery disease, because it's a major, major player in what you'll see, every day at the bedside. Two, heart failure, cardiomyopathy, heart failure conversation. And then three, shock. So those are the three things from that chapter that we're really going to focus on. So the rest of it, I'm not saying is not important, but for the purposes of the sake of time in this class, these are the three things that in this course we really do focus on pathophysiologically speaking. So coronary artery disease, heart failure, and shock are going to be the three alterations of cardiovascular function that we'll be talking about, in great detail for this course. So just wanted to make sure I said that. One second. I just always want to check myself. Okay, good. Okay, so here are those objectives that reflect that. And so the first thing we're going to sort of start with is the conversation about atherosclerosis or arteriosclerosis. You'll hear those terms sort of used interchangeably, and you'll hear me use those terms sort of flip-flopping back and forth between both of those terms interchangeably, even today during the lecture. I think technically one is sort of a subset of the other, so I think atherosclerosis is sort of the beginning or sort of the syndrome of the sort of disease arteriosclerosis, if you want to be super specific. But I'm not going to sort of worry about that. I'm going to actually kind of use the terms interchangeably. And what I mean by that is it is a chronic disease of the arteries, of the arterial system. So it's an abnormal thickening and sort of hardening, almost like a sclerosis or a sclerotic formation of the vessels. And what causes arterio/atherosclerosis is accumulating lipid-laden macrophages within the arterial wall, within the lumen, the walls of the artery themselves. It's this sort of buildup of blood cells, of lipids, of cholesterol bodies, of all those wonderful things we have in our diet that end up getting deposited in our arteries. It's the buildup of those things that lead to something called a plaque. Okay, that is the lesion. That is the formation that forms inside those arterial walls. Now, these plaques, these atherosclerotic plaques, can form in any artery in the body. It doesn't necessarily have to be in the coronary arteries or the cerebral, arteries that feed the brain. It can happen anywhere. It happens in the legs a lot, where you can get sort of decreased blood flow to the legs. That's called peripheral artery disease. I'm sure you've probably heard of that, PAD. There's commercials for drugs and stuff for it on television a lot. But certainly, even despite the fact that these can form in any artery in the body, we're certainly going to be focusing on the fact of what kind of havoc it wreaks when deposited, if you will, into the coronary arteries. But as you see here, leading cause of coronary artery disease and cerebral vascular disease are these athero- or arteriosclerotic plaques. Okay? So really to start off the day, we're going to sort of zoom in sort of this micro level and looking at what those plaques really look like, how they're formed, sort of what are the risk factors and what are the leading causes for these types of plaques, these lesions on the inside of the arteries to be formed. And then after we sort of spend some time with that, we'll zoom out and we'll look at the big sort of discussion of coronary artery disease and what that sort of looks like and what that sort of means for the patient itself. So, see, there I go. Now I have atherosclerosis on the board. So like I said, you're going to see it flip-flopped. So let's talk a little bit about the progression. On a micro level, let's talk about the progression of how these atherosclerotic plaques form. So progression. One, the first thing that happens inside the artery is that it begins with some sort of injury to the endothelial cells that line the artery walls. Now, in the case that we're talking about, the injury could honestly be the deposition of those lipids, of those cholesterol-laden bodies, right, from our diet. Those, they're foreign. They're foreign things. They're foreign objects that do not belong inside the arteries, that do not belong sort of on the artery walls. So that is considered an injury to the arterial wall. Now, those lesions that sort of form there progress from sort of this simplistic endothelial injury and sort of dysfunction of that arterial wall. Then once you start to get sort of more and more accumulation of those cholesterol bodies to that wall, you'll actually see, if you could actually sort of look inside the artery wall, you'll actually see what they call a fatty streak, where you actually start to get a true deposit of those bodies. Then it hardens and becomes a fibrotic plaque. And then ultimately you end up with something called a complicated lesion on the inside of the artery walls. Why? Take a step back for a second, and let's talk a little bit about what we've talked about already this semester when discussing the whole issue of endothelial injury and damage and the inflammatory process and things like that happen on the inside of the vessel walls, like when we talked about immunity and inflammation and things like that. Why might a foreign object in the inside of the arterial wall, be it either sort of the beginning stages of a fatty streak or an actual more sort of progressed fibrotic plaque, what other things may come to that site? This damage on the endothelial wall. What other things would you expect now, given your knowledge of inflammation, would come to that site in the inside of the vessel as well? What do you know? White blood cells, what else? And specifically white blood cells, what kind of white blood cells do we know? Macrophages, did you guys say something else? Macrophages are the big one, right? Okay, so white blood cells, what else might come to this foreign body, this inflamed area here within the vessel wall? What do you think? Platelet? Yeah. Mm-hmm. Clotting factors, platelets, right, exactly. So the big thing that you're going to see here is aggregation of platelets and clotting factors, fibrin, good. What else? Anything else you can think of? Those are really the big ones, right? White blood cells, platelets, and what you'll start to see there because of that aggregation of platelets and those clotting factors is what will you start to see around that plaque, around that endothelial wall injury? The formation of a clot, right? You're going to start to actually see blood clotting, platelets aggregating in that site. That is what sort of is this term of a complicated lesion. The reason this lesion, this plaque, is now complicated is because not only now do you have these cholesterol bodies, these lipids sort of blocking and injuring that endothelial wall, now you're getting complicated because your body's starting to react to it like it would any other injury to the vessel wall, with platelets, with white blood cells, with inflammatory processes. Now, what might that do to the inside of a vessel, to the inside of an artery specifically? What might that do in terms of flow of blood? You've got a plaque, and now you've got all these other blood cells coming to this area and starting this sort of inflammatory process. What do you think that might do to blood flow in that area? What's that? Decreases. You're going to slow down. You're going to slow that blood down, right? Because there's only so much room in these arteries, especially when you're talking about super, super little coronary arteries. There's only so much room inside those lumens, inside that, the diameter. So once you start building up all this junk, for lack of a better word, you're starting to talk about impedance of blood flow, right? So risk factors for this progression of atherosclerosis would be things like hyperlipidemia, high cholesterol. Hope that's kind of an obvious one. Diabetes, smoking, hypertension. And with the exception of hyperlipidemia, that's pretty obvious because obviously you have that buildup of plaque inside the arterial walls. But why might diabetes, smoking, and hypertension also cause these complicated lesions? It may not be quite as straightforward because it's not necessarily lipid plaques forming. But why might these other three things sort of cause the same sort of process, pathophysiologically speaking? What do they have in common? Diabetes, smoking, and hypertension. What might they do to the vessels? Anyone know? They damage them, right? Diabetes, hypertension, super, super hard. Super, super stressful on arterial vessels, right? So it may not be necessarily a plaque that's damaging the vessel wall. It may be the actual pathophysiology of those diseases that are damaging those vessel walls and causing this complicated lesion, white blood cells, platelets, etc., to come to that area. Does that make sense? So can you see now why someone who's got multiple comorbidities, like perhaps hyperlipidemia with the actual plaque there, and then also say hypertension or diabetes that's just purely damaging the vessel walls because of the pathophysiology of that disorder, you're talking about multiple double whammies here for these people in terms of the health of the inner walls of their arteries. Does that make sense pathophysiologically speaking? Mm-hmm. A lot of different reasons for why that might help. One, exercising would obviously, in the terms of, the case of diabetes, would actually decrease that sugar, would decrease the blood glucose, which then is less damaging to the vessels. Because it's those swings in sugar, the swings in blood glucose, that are really hard on those little capillaries. So the littler the blood vessels, the harder it is, the more sort of damaging hypertension, diabetes is to those vessels. Same thing with hypertension. So yes, that is true. And then the other reason is, yes, the better circulation you have, the more you sort of pump things through there and sort of filter things through, and there's an increased flow, the less risk you have of those things depositing. Was that your question? Yeah. So what these things cause ultimately, and sort of the patho of why these plaques are bad, is because one, you have decreased blood flow, so you have inadequate perfusion to any tissue or organs distally to that blockage, distally to that roadblock, so to speak, in the artery, which obviously is going to lead to ischemia to those distal tissues. And then ultimately, if it's not turned around and you don't increase that blood flow to that area, you go from ischemia to actual tissue death, so necrosis of those tissues more distally to that blockage. Does that make sense sort of on a general sort of micro level? Okay. And here's kind of some good visuals of that. So here's a normal artery. You see this nice open sort of diameter of this artery. You can imagine how well blood is flowing through here. Here you see this disease-occluded artery. Look at how small this opening is for blood to get through, as opposed to this, right? We're seeing major blockage and impedance, like I said before, of blood flow to those distal tissues. To whatever tissue is distal to that, it's going to start to look ischemic. So if this is a coronary artery, what's distal? What's past this blockage that's missing blood flow now? The myocardium, right? That major sort of, bulging bicep muscle of the heart now is ischemic, is lacking blood flow. If what we're looking at here is the coronary artery. This B picture here is a small artery actually in the myocardium. So this is where the coronary arteries have actually fed into the muscle tissue. So this is a good sort of cross-section under a microscope, small artery in the myocardium. It's obviously, okay, this is a cross-section of the artery. It's obviously completely occluded. So the things that are stained blue are platelets, or sort of that purpley color. The things that are stained yellow are red blood cells and cholesterol bodies. So you can see between red blood cells, cholesterol bodies, and the platelets in this area, this artery is completely occluded. So remember, anything distal to that occlusion is not getting blood flow, right? We're seeing major ischemic changes going on to the tissues distally from this blockage in this particular coronary artery feeding into the myocardium. Okay, so remember, before we move on to sort of, looking more at a sort of a more macro level, remember that with endothelial injury, not only do you get the injury from whatever reason the injury is occurring, be it because of lipid, cholesterol bodies, or just because of damage to the endothelium because of hypertension, diabetes, smoking, etc., No matter what the reason is, you're going to see platelet aggregation in that area. You're going to see white blood cells, specifically macrophages, coming to that area as part of sort of the inflammatory response. And you're going to see fibrin clots start to form. Okay? So does anyone have any sort of experience at this point already with heparin or patients who have received heparin? This is why patients with coronary artery disease or some type of endothelial wall injury usually get prescribed heparin. What does heparin do? What is it? It's a blood thinner, specifically, anyone know how? It's an anticoagulant, so it's like it's a huge sort of antiplatelet aggregator medication. So, for someone who is coming in with sort of, coronary artery disease type symptoms, quite often, along with a lot of other medications that we're going to talk about later today, quite often they will also get prescribed heparin. Now, is heparin a clot buster? So like in the instance of this artery here with all these platelets and red blood cells in this area, is heparin going to bust this up? No. But what will heparin do? Prevent further clotting, prevent worsening of the condition, either at this site or maybe in another artery that looks pretty darn bad as well, right? So we use heparin a lot with people who are coming in with coronary artery disease or sort of acute coronary syndrome kind of symptoms like in the ER, but also just, in the hospital in general. We'll use heparin a lot because of its antiplatelet, sort of anticoagulation properties. Does that make sense? Okay. All right, and here is just kind of another good breakdown of kind of what we've already said. So damage to the endothelium happens because of all these reasons here, okay? What you will start to see here is sort of this fatty streak on the inside of the lumen. Then you'll start to see that progress into this more fibrotic, fibrous plaque. And then here is, in D, is sort of your true complicated lesion. Look, you've got the lipid, the sort of cholesterol bodies, and then you've got a thrombus. Look at this big blood clot that has formed right here at the site of that endothelial wall damage. Now again, look at the amount of area that the blood has to flow past, as opposed to up here, this open, clean vessel, right? You can imagine why people start to have chest pain, why they start to have lack of blood flow kind of symptoms if this is an artery to their myocardium, as opposed to this. Does that make sense on a micro level? Okay. All right. So increased risk of clots in this area because of all these foreign bodies that are sort of forming up here. Blood cells come to the damaged site just like they would under any other type of inflammatory response that we talked about earlier this semester. And that's why and how you get that complicated lesion. So I just wanted to be clear about that on a micro level before we move forward to actually talking about coronary artery disease, sort of backing up now. What does it look like? What do patients complain of? What do we as clinicians have to be looking out for our patients? And what can we anticipate in terms of treatment? Okay, so that's where we're going to go now. Also, again, coronary artery disease can be any vascular disorder that narrows or occludes the specifically coronary arteries, leading to ischemia of that myocardium. So again, it could be because there's actually a big old honking piece of cholesterol sitting in there, or it can be because the vessel was damaged because of hypertension, smoking, diabetes, etc. Either way, atherosclerosis is the most common cause for why coronary arteries get occluded. Okay? So we know how atherosclerosis forms. Now let's talk about what specifically happens in patients with coronary artery disease. This slide, I'm not going to spend a lot of time on. I know you've discussed in a lot of your other courses and in your past experience the difference between sort of modifiable risk factors, things that people can do to change their risk in terms of developing coronary artery disease versus things that they really can't change. So non-modifiable or major risk factors, like age, family history, etc. Okay, so I'm not going to spend a lot of time on this slide, but you certainly have to consider it, and you certainly have to think about it when discussing someone's risk for coronary artery disease. So I just wanted to say that quickly. Okay, so as I said, coronary artery disease is, for whatever reason, lack of blood flow, getting through those coronary arteries, feeding that muscle, feeding that myocardium that we spent so much time talking about last week. So ischemia, the term ischemia means local temporary. It's not permanent, but local temporary deprivation of the coronary blood supply. Now, there might be lack of blood flow getting to those myocardial cells, but there's still enough there that the cells remain alive. But they may not be functioning as normally or as efficiently as they would be with the full sort of 100% flow of blood that they should be getting. Persistent ischemia or complete, obviously, occlusion of that coronary artery causes what we call acute coronary syndrome, ACS. And what the disorders that sort of fall under this umbrella of ACS or acute coronary syndrome are unstable angina, infarction, and irreversible myocardial damage. And we're going to talk about each one of these specifically as the morning sort of goes on. But again, it's this myocardial ischemia because of the blockage in the coronary arteries that causes acute coronary syndrome, ACS. You'll hear that a lot. And I just wanted to kind of give you that those sort of definitions from the beginning here. So coronary artery disease can diminish the myocardial blood supply and continue to progress and continue to worsen until deprivation impairs myocardial metabolism. Okay, so why? Let's think about that. Let's pull back a little bit, bring everything into everything that we've talked about throughout the semester. Why are we so concerned about lack of blood flow to that myocardial tissue? And how does that impair myocardial metabolism? Talk to me. Why is this an issue? Okay, it decreases the amount of oxygen getting to that myocardial muscle. And then why do we care from there? What happens if you have a decreased oxygen to that muscle? Right, you don't get cellular respiration. You don't get that energy that we need, that ATP production that we need. Remember we talked about the Krebs cycle or the citric acid cycle at the beginning of this semester. We talked about how much ATP you make with oxygen present and how much ATP you make without oxygen present when you switch into sort of anaerobic respiration. It's how much versus how much? How much do you get with oxygen? 36. How much do you get without? 2. The heart cannot function the same with 2 molecules of ATP as it can with 36. That's why we as nurses, we as bedside practitioners care, right? That's why we care, obviously, to know about cellular respiration, but why we care why that muscle's not getting that oxygen, because I can guarantee you that myocardium for that poor patient in the bed is not going to function the same with 2 ATP as it is with 36, and that's why we care. Okay. Now, let's talk about some of these terms, because honestly, in my mind, as an emergency practitioner, it's pretty clear to me that this sort of ACS, coronary artery disease sort of situation is along a continuum from sort of not great but survivable along this continuum to major necrosis and death of myocardium. So let's talk about the beginning all the way through the end of this continuum of coronary artery disease. Okay, so talk through the progression from sort of transient ischemia to actual now injury of the myocardium to infarction, injury, and death of the myocardium. So the first one, stable angina. So this is sort of defined as the gradual luminal, the lumen of the artery, narrowing and hardening of the vessel walls, of the coronary artery vessels specifically. Affected vessels cannot dilate in response to increased myocardial oxygen needs, right? So when we exercise, when we exert ourselves, normally our coronary arteries that feed into our heart muscle can dilate to allow for increased blood flow that needs to get to that myocardium when you're, increasing your heart rate during exercise or during fight or flight or whatever it may be. So someone with stable angina, with this narrowing, sort of hardening of those coronary arteries, can't do that. They can't dilate their vessels in response to or to compensate for increased activity. So what do you think might happen then to someone who has what we, again, coin as stable angina when they start to go up a flight of stairs or when they start to walk on an incline up a hill to get back to their house, from their morning walk. What do you think might happen when their vessels can't dilate, when they can't respond to that increase in activity? What do you think happens? What's that?
High blood pressure.
Okay, perhaps high blood pressure. Good. I was going to say, how are they going to feel? They might be short of breath. They might start to have chest pain. They might start to have chest discomfort. The same way that your leg starts to have cramps, starts to have discomfort when you haven't run in a while and you decide, okay, I'm going to go out and run 4 miles. The cramping, that tired, pain, crampy feeling that you get in your legs when you're maybe a little out of shape, is that same reason for why you have that people have that feeling in their chest when they've got the decreased blood flow because of this inability to sort of dilate and allow for more blood to get to that myocardial muscle. So another way to think of stable angina is that it's predictable angina. And what I mean by that is a very classic sort of story that you might hear a patient tell you of stable angina is, okay, let's say there's a gentleman coming into the ER who tells you that I know I have stable angina. And what that means is I go out every morning and take my 3-mile walk, right? No problem, no chest discomfort, no shortness of breath. But it's only if I know, I go to the park, right, and there's some steps in the park that I have to go up. It's when I go up those steps that I feel some chest tightness and some chest discomfort. Or if I am running late and I realize I have to get home and I pick up my pace a little bit as I'm walking, I'll start to get chest discomfort then. But he can tell you. He can tell you the pattern. He can tell you when he can predict to have his chest pain. Another sort of way to think about stable angina is that it's pretty fixable with nitrates, with nitroglycerin. So the same sort of story would be the guy would come in and say, I can go walk my 3 miles in the morning. If I do happen to go up the steps in the park or I do have to pick up my pace on my way home and I start to have chest pain, I know that I can sit down on the park bench, pop one of my sublingual nitroglycerin tablets under my tongue, and in 5 minutes that pain goes away. So if you can stop the pain with either nitroglycerin or with sitting down and resting, that's also a predictable pattern of chest pain, and that's still considered stable angina, meaning that the blockage to the myocardium is not so bad that rest or nitroglycerin can't make that pain go away and increase the lumen of the vessel and get that blood flow back to the myocardium. Does that make sense? So again, stable angina is chest pain, but on a predictable pattern. Does that make sense? So clinical manifestations of someone who has stable angina would be, again, them saying they're having some sort of substernal chest discomfort, either tightening or a squeezing or an elephant sitting on my chest kind of sensation. Sometimes it's mistaken for indigestion because it does have sort of a burning quality to it in sort of that epigastric area. So sometimes think, oh my God, I'm having like the worst heartburn of my life. So it's oftentimes mistaken for indigestion. They can become diaphoretic, so sweaty. They might feel nauseous. They actually might vomit. They might feel like they're going to pass out, so syncope. Again, you have that classic complaint of left arm pain. Anyone know why they have that sensation of left arm pain? There's a couple different theories of why. Right. It's actually kind of referred pain because the same nerve that feeds the myocardium, that feeds the heart, also then feeds the left arm. So, or innervates, I should say, the left arm. So it's kind of a referred pain. Good. And they might feel shortness of breath, as was already mentioned. Okay. So these are the things, these are the symptoms that someone might feel with stable angina, meaning they're fine until they increase their effort. They increase their activity. Okay. Something else, if this gentleman came into the ER and said, like, I know that I have stable angina, but I still walk, I still exercise, but today I had to go up those steps in the park and I started to have chest pain. If you would hook that guy, right when he was having chest pain, if you would hook him immediately up to an EKG, you actually do see changes on the EKG with reversible ischemia. So let's talk a little bit about the changes that you'd see on the EKG. We talked about what a normal EKG looks like last week. Let's talk a little bit about what you might see with reversible ischemia on an EKG should you hook this guy up to the EKG right then. Okay? So here's my isoelectric line. You've got the P wave, Q, R, S, T. What you see on an EKG with reversible ischemia is a ST segment depression. So let's talk a little bit about this, right? We have P, this darn marker, P, Q, R, S, T. The area on the EKG that's called the ST segment is this area between the S and the T. So this area right here on the EKG is considered the ST segment. So with reversible ischemia, if you would hook this guy up to the EKG right then, you see ST segment depression. So what this looks like is instead of the S wave coming back up to the isoelectric line before the T wave, it looks like this. See the difference? See how the ST segment is depressed below that isoelectric line? That is considered ST segment depression. And that is, listen up, wink wink, that is a sign of reversible. You can fix it. It's not true necrosis yet. You can turn it around if you open up that coronary artery, but it's a sign of reversible ischemia. ST segment depression. Depression below that isoelectric line. The other thing you may see is what they call a flipped T wave, meaning instead of the T wave going up over the isoelectric line, it could actually be sort of like this, under the isoelectric line. But what I truly, truly want you to sort of understand today is this issue of ST segment depression. Okay? How do we treat it? What did I say this guy in my little story would always say helps? Rest and nitrates, taking a nitroglycerin. Why do nitrates, and a specific type of nitrate is nitroglycerin, why do nitrates help? What do they do? What's the mechanism of action? Very, very potent vasodilator. Good. Very good. So if we're having pain because of constriction and narrowing of that coronary artery, we take a potent vasodilator, dilates the arteries, more blood goes to the myocardium, pain goes away. Done. Fixed. Stable angina. When that pain goes away and you increase the blood flow to the myocardium, the ST segment depression goes away. Boop. Pops right back up to the isoelectric line. Looks pretty. Didn't even know that the ST segment depression was there. But how often can you take nitroglycerin? Every 5 minutes, up to 3 times, 3 tablets. What is a very common side effect of taking nitro? Anyone know? Headache. Why? Vasodilates those arteries in the brain, in the head. Very good. Very good. So something to teach your patients about, major education of your patients that take nitrates, is your chest pain may go away, but you might get a headache. Take one for the other. Good. Anyone have any questions about sort of the definition or how we sort of look at stable angina clinically? Okay. Again, no necrosis, no actual injury or death of myocardial tissues in this scenario, because we reverse it, we fix it, we turn it around with rest and nitrates, and blood flow returns, and there's no permanent damage to that myocardium. Okay, next one, unstable angina. Okay, so this is different than stable angina because, one, it's either new onset angina, so someone who's never had chest pain now all of a sudden is having this chest tightness, chest discomfort, or stable angina that is now occurring at rest or that is occurring with increased severity or increased frequency. So again, let's take a look at this gentleman that I already sort of spoke about. And we knew that his predictable pattern of chest pain was with stairs or increased exertion upon walking, right? Now he's coming to you saying, I'm having that same sort of chest pain when I just go out for my leisurely 3-mile walk. And it used to be only whenever I would go up steps or when I would sort of increase my pace. And now I'm just having it when I go out for my leisurely walk. Or I'm having it when I'm sitting on the couch watching the evening news. This is now unstable angina. It's angina that is increasing in its severity, increasing with rest, or it's taking on a new pattern. It's not sort of fitting into that normal sort of predictable pattern that someone once knew or once had. Unstable angina is certainly worse than stable angina because it truly is a predictor of an impending infarction. So things are getting worse now. There's an increased severity of that occlusion of that coronary artery. And we're certainly worried about people coming with unstable angina symptoms of an impending MI, an impending infarction. So clinical manifestations are the same, though. The chest pain, the diaphoresis, the nausea, vomiting, the shortness of breath, the left arm pain, sometimes jaw pain, etc. You will also see the same changes on the EKG with someone with unstable angina as well. You will see that ST segment depression and/or the flipped T wave. Again, both of these things can resolve on the EKG as pain resolves. And the pain resolves because you get increased blood flow to the myocardium, right? So these are the kind of patients that come into the ER that we are throwing, the kitchen sink at them in terms of medication management, because these are the patients that will turn into an MI if not treated, if not turned around. So let's talk a little bit about the treatment of someone with unstable angina. I'm going to try to use a different marker because that purple one is running out. Give me that one too, just in case. Thank you. Okay, so these are the people, obviously, that as soon as they're coming in complaining of this, we're hooking them up to the EKG, right? We want to know, do they have ST segment depression or do they have something worse on their EKG? We're also planning, as the nurses, on giving them, like I said, sort of the kitchen sink in terms of medical management. One of the acronyms that I always use in the ER for medication management of unstable angina, of someone coming in with acute chest pain, is MONA. Anyone heard of this and familiar with this? Okay, let's talk a little bit about what it is. Oops, sorry. Stepping on stuff. MONA. Someone's coming in, complaining of these symptoms. Their EKG looks like this. I'm going to start the MONA protocol on them. Anyone know what M might stand for? It's all medication. Every one of these is going to be a medication. Morphine, okay? Why might morphine, usually 2-4 milligrams, somewhere in that range, why might morphine be beneficial in this situation? Someone's coming in with, oh my God, an elephant sitting on my chest, I can't breathe, I'm having pain. Why might morphine be beneficial? Okay, let's say it again. It's fast, good. But what is it actually going to do for the patient? Okay, so it's going to help the pain. I mean, it's a narcotic. It's going to help their pain. But anyone know what else morphine does? Okay, good. Can calm them down, kind of slow down their breathing, slow down that increased myocardial oxygen demand that they might be having. And what else? Yeah. Decrease oxygen hunger, decrease that myocardial oxygen need. And also, morphine is a vasodilator. It can actually vasodilate as well and open up those coronary arteries a little bit. So pain decreases anxiety and actually helps physiologically vasodilate a little bit to get more blood to that myocardium. So morphine's used all the time for that purpose. Oxygen. Again, probably hooking them up to a nasal cannula, 2-4 liters. Why might oxygen, and sometimes we'll consider oxygen as a medication. It's an intervention, so to speak. Why might oxygen be helpful in these patients? What do you think? Why are they having pain? Decrease oxygen, right, to that myocardium. So even though there might be a sort of a closure or a blockage in that coronary artery that's causing the pain because of decreased oxygen, let's just load them up with oxygen. So whatever blood is getting through that opening, it's oxygen rich. And let's try to increase the oxygen to that myocardium in that respect. Okay. N, nitrates. We already talked about why that's helpful. Again, you can do that. Give them a sublingual nitro underneath their tongue that just dissolves. 1 tablet every 5 minutes for 3 tablets. And then A is aspirin. Why is aspirin helpful in this situation? Blood thinner. It's an antiplatelet aggregator. Again, if there's a clot, a complicated lesion blocking that coronary artery, is the aspirin going to break that open? No. But it's going to prevent worsening. Or a clot. It's going to prevent a clot formation in another coronary artery or in another problem area that might be increasing their risk as well. Good. And this is usually a baby aspirin, so it's usually like 81 milligrams. And we'll just say, we'll hand it to our patient and say, chomp. Just bite it like candy. It makes it work faster. It releases it a little bit quicker into their system. So oftentimes we're giving them a baby aspirin and just saying, chew it. And it tastes awful and bitter, but it's the least of their problems right now. I mean, honestly. So those are the 4 medications that sort of consist of that MONA protocol. All of these things, the purpose, the goal of all of these things is to decrease their myocardial oxygen demand, but give them more oxygen, right? To decrease how much oxygen that heart needs while you're increasing the amount of oxygen they're actually getting. The other 2 things you'll give quite commonly, and again, I'm giving all these at one time. Like I have all these things in my pocket and I'm doing them all at the exact same time. The other thing that you'll be doing is quite often giving a beta blocker. The big one we usually use in these situations is metoprolol. Remember, anything that ends in LOL is a beta blocker, and metoprolol is a big one that we usually give. What's the mechanism of action of beta blockers? Anyone know? Why would we be giving this in a situation to this particular patient? Anyone know what beta blockers do? Mm-hmm.
Well, I can't remember if metoprolol is like a beta 1 or selective beta 1, beta 2, but it stops those receptor cells from restricting.
Okay. Good. So what would that do in terms of heart rate and blood pressure? Decreases blood pressure. Good. And it also, honestly, decreases their heart rate as well. So a beta blocker will decrease someone's heart rate and decrease their blood pressure. Now, if you are a bedside nurse taking care of this patient and they ask you, why are you giving that to me? How in layman's terms might you describe sort of the purpose of why you're giving this medication? I can tell you what I usually say, but how might you say it? Why metoprolol is so helpful in this situation? Anyone want to give it a whirl? How you would explain this and educate your patient? It actually just, this is what I tell my patients, it actually just decreases how hard your heart has to work right now. Obviously your heart's not getting the amount of blood and the amount of oxygen that it needs, so let's just decrease its workload. By decreasing the heart rate, by decreasing the blood pressure, so it decreases that pressure in the vessels that your heart has to pump against to get blood out into the tissues. You're basically just decreasing the workload of your heart by giving metoprolol. And then the last one that sort of is included in this treatment protocol is heparin, and we talked about why that's helpful because it also is an anticoagulant to decrease any clot formations that might be forming in that complicated lesion area. Okay. These are the patients, these unstable angina patients, these are the patients that if they're not emergently hospitalized and they're not emergently getting treated in the ER, like I said, I'm giving all these things at one time. I'm throwing the kitchen sink at them all at the same time. These are the people that have the greater chance of it actually turning into an actual MI. So we graduate, if these things do not happen, there's a really good chance that you graduate from just ischemia to now complete lack of blood flow, complete lack of oxygen, and you've moved into sort of the infarction, injury, necrosis area, danger zone, so to speak. Does that make sense? I think this is why I like cardiovascular so much, because I'm such like a linear person, like let's take the right steps and get to a goal. I love this because I love when, these poor patients, I shouldn't say I love this, but I love it when they come in, their EKG looks like crap, they're diaphoretic, they're in pain, we give all this stuff, and they're pain-free, and their EKG looks better, and they're sort of stabilizing out. I love that, like get my list checked off, and boom, you're better. And it actually happens very, very commonly like that. These things do a really, really good job of opening up that vessel, getting that blood flow to the myocardium, and actually making the patient better. Yeah? Yeah, I mean, usually, but the thing is, and how I want you to start thinking is that one, sometimes like in an emergent situation like that, there's a bunch of already sort of written out protocols that if you know like their EKG looks like this, you just kind of start it. But the other thing is just to anticipate. That's what really makes us really good as nurses is that yes, we may need a doctor's order, but I know what the doctor's going to order. So let me anticipate it and let me get ready and geared up. Let me get the oxygen ready. Let me pull up these medications out of the Pyxis. Let me get this ready because I know what the doctor's going to order and I'm going to be ready for it in my pocket already kind of thing. Does that make sense? Was there another question here? Yeah. Yeah. It depends. Sometimes it depends on what their EKG looks like. Sometimes we'll just give, if someone's coming in, they've got sort of moderate risk, we'll give them 81. Sometimes we'll give them 4 to chomp and chew to equal sort of 325, like the normal dosage of an aspirin. It just kind of depends on what their clinical picture looks like. Yeah, good question. All right, that's unstable angina, and that's what it would look like of a patient coming into the ER and what treatment would look like and what we as nurses can anticipate in terms of treatment. Again, usually these things will make the pain go away and make their EKG look normal again. Ta-da! I love it. Closure, right? Nice little package, tie a bow on my patient. All right, that is unstable angina. All right, let's see, what time is it? Okay, let's move to this next one and then we'll take a break. Okay, let's say this poor person did not come in, was having all of these symptoms, did not come into the ER, did not get subjected to our lovely Mona protocol with beta blockers and heparin. They sat at home thinking it's going to get better, it's going to get better, it's going to get better. And it doesn't get better. And now we've moved into relieving just transient reversible ischemia to the tissue, and now we're moving into myocardial infarction, MI, heart attack, okay? Now we've got complete, sudden, and extended obstruction of the myocardial blood supply. What do you see? First you have injury, and then if you still don't get it fixed, you move, injury of the myocardial cells. If you still don't get it fixed, you move into cellular death of those myocardial cells. So cellular injury, this happens really quickly. Cells of the myocardium get injured after only about 8 to 10 seconds of decreased or lack of blood flow. If you would actually look at the myocardium, it actually looks bluish and cyanotic, and it would actually kind of be cooler to the touch. Now again, we're not doing that as clinician bedsides, but bedside clinicians, but at least you sort of know that like there literally is a decreased blood flow, there literally is a decrease in metabolic activity in this muscle, and it would actually look blue and cool. The reason for that is the oxygen reserves that we have in our myocardial muscle gets used up really quickly when there's complete lack of blood flow. So that is, after complete cessation of flow, the oxygen in the heart is gone pretty quickly. Myocardial cells that are deprived of oxygen and or nutrients obviously aren't going to work, right? So the muscle begins to not work. So you have decreased contractility of those ventricles, which obviously leads to decreased pumping ability. So this is when you're starting to talk about lack of blood flow to the rest of the organs because the blood is not pumping out, right? So this is when people lose consciousness because you've got lack of blood flow to the brain. This is when you see issues with, kidney function because you've got lack of blood flow getting to the kidneys because the heart is not pumping and contracting and getting blood out to the rest of the body. All of that you see with cellular injury. Again, if you still don't get that fixed, you move on to complete cellular death. And this occurs after only about 20 minutes of ischemia. So again, this guy sitting on his couch thinking it's going to get better, it's going to get better, maybe it's just heartburn, maybe it's just heartburn. I mean, tick-tock, time is muscle here. And it really does occur only after about 20 minutes of ischemia before irreversible, permanent hypoxic damage is done to those myocardial cells. And necrosis, death, permanent death. That function of that muscle will not come back ever. And this is when you start to see the release of that intracellular troponin. We talked about the need for troponin in cardiac muscle contraction last week. this is when you start to see troponin get released into the bloodstream because of necrosis of these muscles cells. And it's really with this cellular injury, not even so much the cellular death, it's with this cellular injury that you start working, the heart starts working off of anaerobic activity instead of aerobic activity. And again, you can imagine all the trouble that causes in terms of sodium potassium pumps and all the energy driven activities of the heart. You can imagine why the heart stops functioning properly. And again, in terms of cellular death, that's why troponin is such a help in terms of diagnosing an MI, because you really only get that troponin release when you get actual necrosis of the tissues, of the cells in the heart. And that's why we know if troponin's positive, if it's elevated in the blood, you've had an MI. So basically at this point it's a mess. Clinical manifestations, all the same as the angina that we talked about, only worse and not going away because it hasn't, the blood flow hasn't been opened up back to the myocardium. So all the same things that you would see with angina. And now when you move from reversible ischemia to now death of myocardial tissue, you see another change on the EKG. So instead of ST segment depression, which is a sign of reversible ischemia, now what you'll see in someone with an MI, or the true MI now, is what we call ST segment, again, ST segment elevation. And that looks like this. So normally, here's the isoelectric line. Normally, the S wave should come back up to the isoelectric line to make that T wave, but instead, it goes above the isoelectric line, and the T wave's way up here. This is ST segment elevation. ST segment elevation. And quite often, you'll hear this referred to as a STEMI, ST elevation MI. So if you see this, this is a MI. This is a heart attack. I had a very insensitive attending that I worked with in St. Louis who referred to these when he saw these on the EKG as tombstones. Not only does it kind of look like a tombstone, because then obviously the T wave will come back down to the isoelectric line and start over, but he would refer to these as tombstones. It's not a good sign, right? A STEMI is not a good sign. It's a ST elevated MI. The other thing you may see on an EKG of someone who's actually having an acute MI is something called a pathologic Q wave. This is where I started to get ahead of myself last week whenever I was drawing my normal QRS complex, where I started to get ahead of myself. What you will see with a pathologic Q wave with an MI is, see how the Q wave is like just a little blip here and then the R goes up? What happens with a pathologic Q wave is the Q wave's huge, like 3 times the size of the T wave. And so there's sort of like it's this abnormally large, abnormally wide upon actual visualization that's called a pathologic Q wave. This you see quite commonly when the necrotic damage or the death of the tissue, of the myocardial tissue, is full thickness. So what I mean by that is if you would look at the cross-section of the myocardium, you would actually see that the death of, the necrosis of those cells is like the entire thickness of that myocardial layer. You see a Q wave, a pathologic Q wave, quite commonly when you see that occurring in the myocardium. So, now if someone comes into the ER with an EKG, either with a pathologic Q wave or this ST segment elevation, we're still doing all of those things that I just talked about with unstable angina. MONA, beta blockers, heparin, all that stuff. And you have to do all of that stuff like yesterday because of the complications of what this means. They have complete occlusion of blood flow to their heart. So you're talking about sudden cardiac arrest risk, due to ischemia. You're talking about left ventricular dysfunction. Again, if you don't have blood flow to the left ventricle, it's not going to be able to function properly. It's not going to be able to push that blood out to the entire body like we talked about last week. And you'll see electrical instability. You'll see some lethal dysrhythmia starting to occur because, again, it's the electrical activity that moves through that myocardium. If the myocardium's dead, it ain't conducting electrical activity through that. And that's why this is major. You throw Mona at them all at once. And these are also the patients who are getting ready to go to the cardiac cath lab, where they thread the catheter up into their groin, and they're not even actually doing the groin sometimes. Now sometimes they're using the arm through the artery in the groin up into their heart to actually dilate their arteries, either with a stent, dilate their coronary arteries in their heart, either with a stent or a balloon, and sort of try to very acutely and emergently open up that coronary artery to allow for increased blood flow to that dying, starting to be necrotic myocardial tissue. The other thing that may need to happen for these patients is emergently, or not so emergently, take them to the OR for a CABG. Anyone know what CABG stands for, CABG? Coronary artery bypass graft. So when you hear people saying, oh, I had a triple bypass, or I had a double bypass, or my grandpa had a quadruple bypass, they're talking about a coronary artery bypass graft. That's what CABG stands for. And this is where they actually take a vein, usually from your leg, turn it inside out, because, you know, veins have valves, arteries don't. So they'll turn it inside out so that there's no valves on the inside, so it kind of acts like an artery, so to speak, and just bypass that huge clot or that huge occlusion in the coronary artery so that blood flow can get around it. That's what CABG stands for, coronary artery bypass graft. So again, you're going to see major complications. These are the people that will code. These are the people who will have lethal dysrhythmias because of the changing of their electrical activity. You're going to start to see loss of consciousness, all of those sort of other issues that are occurring in the body because of lack of blood flow, because of lack of ventricular function and shooting that blood up to the rest of the heart, or to the rest of the body. Kind of just to kind of give you some perspective about this. Let's see here, I want to give you the right numbers. With stable angina, so the beginning of this progression, the beginning of this continuum, someone who is experiencing stable angina probably has about a 50 to a 60% occlusion in a coronary artery. So it's about halfway occluded by the time someone starts to feel those sort of stable angina symptoms. Then when you move down the progression to more unstable angina, we're probably looking at about 80% occlusion. And then once we've moved from unstable angina to a STEMI, we're looking at probably pretty close to 100% occlusion for these types of symptoms to be occurring. Also, just kind of quickly, interestingly too, sometimes that these sort of classic textbook clinical manifestations of an MI may not be so classic for women. Women are kind of stereotypically known to have sort of unclassic MI symptoms. So instead of having these sort of classic things, they'll complain of just really severe fatigue or shoulder pain instead of the arm pain. Sometimes they'll complain of jaw pain. Not exactly completely understood why women are kind of known to have aclassic symptoms, but it certainly makes their prognosis worse quite often because they end up not coming into the ER as fast as they should because they don't know that what they're experiencing, you know, the fact that they've had this like profound fatigue for 3 days is indeed an MI, right? So sometimes their prognosis, they do worse once they do finally show up to the ER because their condition is so much worse because they didn't know the symptoms that they were having was an MI. Do you have a question? Okay. It's pretty hard not to. It's pretty hard not to because to have a true MI, it's like I said, almost complete occlusion of the coronary artery. So it's pretty hard not to get some warning signs with, you know, carrying laundry up your steps. Just kind of gets harder and harder and you get kind of short of breath. Or, you know, sometimes they may not know that's what they're having. And so hindsight's 2020. Oh yeah, I have kind of had chest pain the last few times I tried to go out and cut my grass, or something like that. But it's pretty hard to go from perfectly asymptomatic to boom, you're having a STEMI. But sometimes people don't know that what they're experiencing is angina. Good question. Okay. I think this picture is a really good sort of illustration. This right here is sort of an infarct. Actually, no, I want to show you this one. This picture right here is actually a really good picture of an infarct in the myocardium. So see here how this is the myocardial muscle, sort of a cross section. This area right here is sort of yellow and necrotic. And then around it, you see sort of like a hemorrhagic ring around it. So there's some bleeding into the tissue, and there's some hemorrhaging that's going on a micro level inside that myocardium because of the necrosis and the damage done to that tissue. So again, you can imagine if electrical activity is trying to get through this area in the myocardium, it's not going to happen. The electrical activity cannot go through this necrotic, damaged part of the myocardium. So again, we're talking about major sort of lethal dysrhythmias here because the electrical activity is not happening. Not getting through there. And you're starting to see some fatal dysrhythmias that occur in that site. Okay. This also is a really good illustration of how much damage is going on to the myocardium in relationship to what you're seeing in these changes that we were talking about on the EKG. So, normal, this is what it looks like. Ischemia, this is what it would look like with either a flipped T wave, or again, they don't show you on this picture, but ST segment depression would also be occurring in this site. Injury, you have your STEMI, ST segment elevation, and infarction or necrosis with true myocardial full thickness myocardial death is when you see this pathologic Q wave. And just, again, kind of another illustration of what we've already talked about up here on the board. All right. Any questions? Does that become a little bit more clear to you in terms of what we're looking at with cardiovascular patients and the progression from angina to infarction to necrosis and what we do in terms of treatment at the bedside? Does that kind of help illustrate some things? Okay, yeah. Yeah. Yeah, it's not going to get better. It's not going to get better on its own. Now, some of these people who, let's say they have unstable angina and they've got close to an 80% occlusion, some of these people that will be the kind of patient that might be coming in and getting a stent sort of prophylactically to sort of try to open that up, or balloon angioplasty is what they call, where they thread through the artery a catheter with a balloon on the outside of it, and they blow up the balloon, and then deflate the balloon, and hopefully that balloon has sort of pushed some of that plaque to the side, but it's not going to get better on its own. So, this isn't the kind of thing where you say, okay, now start eating better and exercising more, and that plaque will go away. Once it's there, it's there. There might be some medical interventions we can do to push that plaque aside or open it up with a stent, but it's not going away. Good question. Good question. All right, any other questions? All right, let's take a break. Sorry, the break is a little bit later than we usually do it. And then we'll come back and talk about disorders of the pericardium and of the myocardium.